So in this crowded room, I spot an interventional radiologist who fortunately is not only an expert in interventional radiology, but also in delivering educational lectures. So we're absolutely delighted that TC is with us today. He is our beloved ex-clinical director. We love our current clinical director, but he did a fantastic job leading the department for a number of years, dealing with many difficult issues diplomatically, and managed to retain, I think, virtually all friends and make new friends in the department while you were in that role. It was really a terrific achievement. But the great thing is that TC has now returned to his first love, which is getting his hands very, I was going to say up close and dirty, but not at all, and getting his hands very clean and sterile, and using all kinds of catheters and new techniques to deal with a whole variety of predominantly abdominal conditions. He's widely regarded as an expert in this area, speaks at national and international meetings. So we're super fortunate to have him here in the department with us, training our trainees. So today he's speaking to us on portomesenteric vein thrombosis. TC, thank you. We really appreciate learning more about this important condition so that we know what to do when we're faced with something like this in our MDTs or whatever. TC, thank you so much.
Thank you. Thank you, Fiona, for this very kind introduction. So I'm going to talk about portal vein thrombosis, and we will focus on the endovascular intervention on it. However, in order to understand or perform the procedures, we do need to have quite a solid background in terms of the clinical condition itself. So I will cover part of that itself. I would say the condition itself is quite complex. You will see why in a minute. So I apologize in advance that if you're lost halfway through, but I will try to take you through the session. Just click on it, I think. Yeah. So I'll cover the classification and the spectrum of PVTs, and the touch on the controversies and any gaps of the knowledge that we have, and then the clinical management and outcomes. And I'll share some cases to illustrate the role of endovascular interventions. So portal vein thrombosis broadly, you can categorize it as acute and chronic. In some cases, you may see acute or chronic portal vein thrombosis. The etiologies are very important, and it could be cirrhotic or non-cirrhotic, and the management were quite different for those two cases. And of course, we can also see tumor-related portal vein thrombosis, the management of which will go according to the management of the particular cancer, particularly in hepatocellular carcinoma. Just for terminology, when the acute portal vein thrombosis settle down, it will, if it's not treated, if it hasn't been recanalized, then obviously it will progress to chronic portal vein thrombosis. And in the non-cirrhotic cases, we will call it extrahepatic portal vein obstruction. That's the terminology that's used as compared to venous occlusive disease within the liver parenchyma, which is very separate from the extrahepatic portal vein obstruction. And with chronic condition, you will see a lot of collaterals. And so in this case here, you will see mesoportal and also portal-portal cavernous transformation, and also portal systemic shunts where it might lead to variceal hemorrhage. The incidence of portal veins a bit vary, about 10 to 15% in patients with cirrhosis, and then a bit less in patients with non-cirrhotics. But those are the difficult ones to deal with. So in terms of presentations, almost half of them will be asymptomatic, and some of them will present with variceal bleed, and a number will present with abdominal pain associated with systemic inflammation, for example, fever and feeling very unwell. For acute portal vein thrombosis, the 30-day mortality is quite high as 20%. The outcome can be a bit unpredictable depending on severity of the clot and the onset. And the worst fear complication, of course, is intestinal infarction, which carries up to 60% of mortality. If they're not treated, one will progress to chronic portal vein thrombosis, where I told you already there will be countless transformation, and they tend to present with complication of portal hypertension. And that would include variceal bleeding, ascites, decompensation, cholangiopathy, and encephalopathy. The risk factors, we mentioned about malignant portal vein thrombosis, which I wouldn't touch on this very much, purely because the management of which relies on the underlying etiology of the cancer. And we have the non-malignant and non-cirrhotic, non-malignant cirrhosis, and also non-cirrhotic conditions, which I'll deal with a little bit later. So for non-malignant and non-malignant portal vein thrombosis, the outcome is highly variable. About 50% may recanalize on its own, and about 50% may present with symptoms, quite variable. I'm talking now about non-malignant, non-cirrhotic portal hypertension. A third of it will be due to local inflammatory change, for example, following surgery. So not uncommonly in your CT scan, you will see post-surgery and abdominal pain identify portal vein thrombosis. And recently we saw a case of inflammatory bowel disease, diverticulitis that present with INV thrombosis extending into left portal vein thrombosis. The other fairly common cause are patients that will have prothrombotic association, inherited or acquired. The acquired one being myeloproliferative disorders, which is very common in that particular category, particularly in patients with the associated JAK2 mutation. And so when a patient comes in with portal vein thrombosis for young patient, non-cirrhotic, they will do a screen of all those thrombophilia screening. And there are other general kind of predisposition, and also a third of them, we do not know the underlying cause. The mechanism of portal vein thrombosis is still unclear. You will remember vocal stride, where a combination of endothelial injury, vascular stasis, and coagulopathy, which may lead to thrombosis. For patients with cirrhosis, because of high resistance in the portal liver parenchyma, there will be some degree of reduced flow, and therefore stasis could be the key contributing factor for thrombosis. Whereas younger patient with, for example, non-cirrhotic patient, coagulopathy associated with thrombocytopenia or thrombophilia could be the main cause for it. There are a number of controversies related to portal vein thrombosis. Number one is the classification itself. So far, we've been using anatomical classification, but it's not essentially useful. In a lot of management criteria, do we also rely on the severity of the thrombosis? Do we just base on also whether patient is for transplant or whether is being able to recanalize, and also the clot burden? So there's a lot of uncertainty along the classification itself. Second,
I'll just interrupt. There's lots of people in the waiting room who need to.
Oh, let me just admit them. Did I say view or what? Admit all.
Thank you.
Now I need to get rid of this. Sorry, can I just make myself a co-host?
I think it is. Reflecting COVID. 。 Carlos, I was just being really rude about your cricket pictures.
Why are we going to Nando's? I'm joking.
Thank you.
Thank you, Carlos. So for those who just joined in, welcome. Sorry, there was a bit of delay there, but we started talk about acute, chronic portal vein thrombosis, heading into mainly non-malignant portal vein thrombosis. So the natural history and outcome in non-malignant portal vein thrombosis I mentioned before is highly variable. 50% may recanalize and another 50% may present with symptoms. I think I talk about that, the underlying cause. I'm going to jump that. I also talk about mechanism, and I talk about the controversies of portal vein thrombosis on classification, and whether portal vein thrombosis is just purely thrombosis itself or a combination of underlying immunology of dysfunction, which trigger a cascade of clotting disorder that may lead to thrombosis and subsequent inflammation. The role of anticoagulation is also very uncertain, and there is a lot of debate in terms of what type of anticoagulation to use, and also for how long and in which group of patient. And finally, when do we actually recanalize the patient, and under what circumstances that we recanalize them? So there is a lot of controversies. I mentioned about classification. There is a trend towards classify the condition by combining both physiological or functional aspect with the anatomy classification. But you will see that majority of cases, one would recommend anticoagulation. I'm always fascinated by the portal vein. So it is the only vein that joins vein to vein and to the hepatic vein. And also it is unique in the sense that, the size of the vein itself, which is, quite medium, and it's got low pressure. You can see here up to 10 millimeter mercury, and very slow flow, in most cases 20 to 40 centimeter per second. And therefore, in patients with cirrhosis, when there is high resistance in the liver parenchyma, the flow is even going to be slower, and therefore they are more at risk of portal vein thrombosis. And there is high volume flow, obviously, in the portal vein being receiving a lot of mesenteric flow. You may remember your physics Poiseuille's law, where the flow is proportional to the fourth power of the radius. So you don't actually need to reduce the diameter of the lumen to a greater extent to cause quite significant reduction. For example, 50% of vessel reduction here will reduce the flow down to only 6%. So our interpretation from the CT, for example, 50–60% of thrombosis actually has quite a major impact in terms of functional flow and hemodynamics of the portal vein. And then the actual thrombosis itself, both pictures here are thrombotic, section of the portal vein, and one will have focal thickening of the intima here, and this orange bit here is the fibrin, and the other one have a circumferential thickening of the intima of the vein with significant amount of fibrin deposition. And the differences here, I think, highlight or will probably explain why some patients are more responsive to anticoagulation, for example, heparin treatment, compared to others. I won't go into this in much detail, but it's very important, obviously, to distinguish blunt thrombus versus tumor thrombus. And this is the LIRIC classification and or recommendation. Tumor in vein, they need to have unequivocal enhancing soft tissue in the vein, regardless of whether you can see the primary mass. And if you don't see that, then obviously there are other factors that you could consider, whether the vein is occluded with ill-defined wall, restricted diffusion, whether there is primary malignancy seen, and also whether there are any artifacts that may associated with it. I find this criteria, which is not validated, Avena criteria so far in HCC very useful. A is stand for alpha fetoprotein of more than 1,000. V is venous expansion. is enhancement, neovascularity, and also adjacent to HCC. If you see that, the high chance is that the patient will have malignant portal vein thrombosis. And this is the standard kind of recommendation for reporting portal vein clots in clinical and research setting, drawn up by the American Association of Liver Study, and then also endorsed by the Bavino guideline, which is the hepatology guideline. So it mentioned about the time course, recent or chronic, which is recent being less than 6 months. And then the percent of occlusion of the main portal vein, completely occlusive, 50% being partially, above or below that is minimally, and also whether there is cavernoma or cavernous transformation in association with it. And then in terms of treatment, whether it's progressed, stable, or remain or regressed. So something to remember. I mentioned about anticoagulation. The strategies also differ for acute versus chronic, for cirrhotic versus non-cirrhotic. As a whole, low molecular weight heparin has been used widely for patients coming with thrombosis. And we do have to bear in mind there is high prevalence of heparin-induced thrombocytopenia, particularly in patients with myeloproliferative disorder. So therefore, the more heparin you give, they're going to have more thrombocytopenia, and therefore they may present with more bleeding. And it is quite difficult to treat. Yeah, well, on one hand, you want to treat the clot. On the other hand, the more heparin you give, it causes bleeding. So there is a balance you have to consider. I think as a whole, I think the patient needs to be discussed, in the MDT and recent PVT. Most people will administer anticoagulation at least for a minimum of 6 months, and same for acute and chronic PVT. And chronic PVT itself, one will need to identify any risk factors and treat them accordingly. And whether to anticoagulate or not, I think it has to be individualized. Majority will. And for patients that undergone recanalization for TIPS, for example, not all of them needs to be anticoagulated after that, unless they have prothrombotic factors. The current guidelines are quite variable because of the heterogeneous data. Is mainly based on consensus rather than evidence-based. And majority of them will recommend anticoagulation. Inadequate recanalization remains a therapeutic void, because not everyone can achieve full recanalization. And in patients that present with associated intestinal ischemia or congestion, the treatment strategies remain experimental. So what do we do to deal with PVT? The aim obviously to prevent the extension into mesenteric or splenic vein thrombosis, to prevent complication of mesenteric ischemia, and hopefully to achieve adequate recanalization to prevent complication of future portal hypertension. And when do we want to intervene early? If there is suspicion about ischemia, or if we expect low likelihood of success in anticoagulation. I'm talking about cirrhotic patient now. So in terms of the outcome, less than 5% will recanalize spontaneously. About 2/3 of them can recanalize with anticoagulation. And for those that have decompensated cirrhosis, majority of them will progress. And if you stop anticoagulation, about half of them will rethrombose. And this has main implication in patients who are on liver transplant waiting list because portal vein thrombosis has poor prognosis in terms of outcome following transplantation. A number of studies that I listed, all of them indicates that the addition of TIPS or endovascular intervention will improve the outcome and recanalization. We talk about the impact of portal vein thrombosis after liver transplantation. These two meta-analyses included quite large number of patients, nearly 900 in one group, and then nearly over 7,000 in another. And both analyses demonstrated that there is significant higher mortality risks associated with patients with portal vein thrombosis after transplantation. And so it is important then to address that particular issue. And this is a paper from Chicago, who is renowned on their aggressive intervention for recanalization. So they have 35 patients for portal vein recanalization via TIPS compared to those who have mild degree of portal vein thrombosis, or 14 of them. One thing to say is almost all of them have normal SMV and splenic vein. Their goal is to achieve recanalization, so at the time of liver transplantation, the surgeon can do end-to-end portal vein anastomosis, which will have a better outcome compared to a different variation of other anastomoses. You can see here the survival are pretty similar. Those patients we have complete portal vein thrombosis did not do worse than those that have a mild degree of portal vein thrombosis, highlighting the fact that recanalization will help to optimize the outcome of patient with transplantation with pre-existing portal vein thrombosis. We move on to those patients who are non-cirrhotics, and spontaneous recanalization are very, very rare. This patient, a different group of patients I mentioned before, that are younger, and also they might have underlying prothrombotic association. And if we give anticoagulation early, probably about 30% will recanalize compared to 70% of those cirrhotic patients. The predictors of non-recanalization or progression to bowel ischemia, there are a number of factors here. One, if they are associated JAK2 mutation, this is one of the mutation seen in myeloproliferative disease. If they have new ascites, or if they have extension of the thrombosis into the splenic vein, SMV, and also small little venous arcades. There are multiple factors that may explain why recanalization may fail, depending on the underlying cause, the onset, which vessels is involved, any further intervention, for example, any endovascular intervention involved, etc. I'm going to move on now to the focus of my talk here, which is on TIPS and portal vein recanalization. So I think TIPS is not quite an easy procedure itself, but when we apply that to a patient with portal vein thrombosis, I think the complexity does increase, particularly if they got associated other thrombosis episodes. So in general, in cirrhotic patient, if the patient presents with partial or complete PVT, in theory, generally it's feasible for us to perform TIPS and recanalization. In patient with carcinoma, where you see obliteration of the native portal vein, I think the intervention is quite challenging, will require some degree of experience and expertise. For non-cirrhotic patients, it is the techniques itself an extension of those that we use for cirrhosis. I mentioned before, they tend to have younger patients, they tend to be younger, and they tend to have hypercoagulopathy, and majority of them will have countless transformation, i.e. you can't actually see the portal vein itself on cross-sectional imaging. You want to recanalize them, so it is quite tricky. And I think the complexity does increase with thrombus extension into the splenic or the SMV. Before I go through the actual procedure itself, just give you a basic introduction on TIPS so that you understand what we do and the extension of it. So the transjugular intrahepatic portosystemic shunt essentially means you come access via the jugular vein, usually the right side, through the SVC into the heart, into the IVC, and then you select the hepatic vein here, and you try to connect the hepatic vein with a branch of the preferably right portal vein, and then you deploy a stent in between to create a shunt. You will see the stent here. Most of it is covered stent graft, and then the last 2 centimeters here is uncovered to allow some flow to go through the liver, and the rest will be driven to the systemic circulation, and therefore decompressing the pressure in the liver. So that's the function of the TIPS procedure. The standard indication will be refractory acute variceal bleed after they fail endoscopy intervention. The second intervention is refractory ascites that they refractory to medical therapy, where they have to keep coming in for weekly drainage, for example. Those are the two common standard indication that we do for TIPS. The actual procedure, as I mentioned, coming from the jugular to the SVC, right atrium, IVC, right hepatic vein with a catheter into the wedge hepatic vein to a wedge venography to highlight when you do a wedge venography, there's pressure from, remember they are connecting, yeah? The hepatic vein and the portal vein, as I say, is the only side where vein connect to this vein in the body. So there will be back pressure into the portal vein as long as the portal vein itself is patent. So you see this reflux of contrast medium here into the portal vein. You can see that there, and then you use this very sharp needle from the neck and try to puncture from the hepatic vein into the portal vein. Use your cross-sectional correlation, or you can use your imagination to see whereabout is the portal vein, and you puncture that, and then you got into the right portal vein. And then once they are in there, of course, you dilate the tract in the liver parenchyma between the hepatic vein and the portal vein to form a tract, and then you deploy what we call the stent graft here. This is the graft here covering the tract, and then the last 2 centimeters here to allow some flow. This is uncovered stent, the last 2 to allow some flow into the liver. The advantage of stent graft is it prevents intima hyperplasia and therefore reduces the risk of future thrombosis. And here's the tips where the flow from the portal vein will be shunted away mostly into the systemic circulation, and you achieve what you want to achieve in terms of the pressure gradient. So that is the standard kind of TIPS procedure. And you do a follow-up with ultrasound and follow it up regularly, make sure it's fine. There are potential complications, as I say, capsular perforation, hemoperitoneum is one. You can just imagine puncturing the right hepatic vein to the right portal vein. May not be straightforward, and you can also puncture the artery, the collaterals if there are any, and bile duct, etc., and exercise complications. So not a small undertaking, usually done or almost exclusive done under GA. So moving away from the standard TIPS procedure, we're talking if we were to recanalize the obliterated portal vein or the clotted portal vein, the standard TIPS procedure may not be sufficient. And there are unconventional alternatives. One is to directly puncture the portal vein itself. And you can still use a transjugular technique, but it will be rather complex. But majority of my work is based on this approach. You can also use a transhepatic approach, meaning puncturing the peripheral portal vein percutaneously at the same time transjugularly, and then you marry the two at some point. And it needs assistance with balloon catheter and also snaring in order to get the access. And increasingly, splenic transsplenic approach has been described for those patients who have patent splenic vein to allow the TIPS to be deployed. A couple of applications in terms of transmesenteric, directly puncture the SMV or IMV percutaneously, and again, will require assistance with balloon or snare. And there were a couple of case reports on puncturing the carcinomas on the collaterals and then forming the TIPS as long as the collateral also drain or communicate with the SMV or splenic vein. So I've been asked to do that a couple of times, but the surgeons have not agreed to do that one. I think it's quite risky. So I'm going to give you some examples here. So here's case number 1, direct portal vein recanalization, 60-year-old man, 5 days post-liver transplant, and then presented with portal vein portal vein thrombosis and SMV thrombosis here. Obviously, he just had a transplant. He doesn't need a TIPS here because, we don't really, he's got a new liver. So to access this, I'll access this percutaneously, directly ultrasound puncture into the portal vein and balloon it, and then leave a catheter in to infuse heparin or TPA lysis. And this is the result after 72 hours. You can see, full recolonization of the portal vein. So this is quite straightforward as a case. The more complex transjugular approach. So this is a patient that I did probably more than 5 years now. He was 17 years old from Scotland, actually, and refer here with sudden abdominal pain and occlusion of the portal vein. And we gave systemic anticoagulation, including TPA and heparin. You can see a little bit of recolonization if the projector allows you to see that. But as a whole, the vein is still occluded. We went on to perform the TIPS procedure, and you can see here clotted portal vein here, very irregular, nothing like normal portal vein. Created a shunt here and deploy a stent. You can see, despite, after balloon dilatation, etc., there is still a substantial amount of clot in the portal vein. And if you, this is a catheter here into the SMV branches, you can see there is no antegrade flow here into the portal, meaning it's completely occluded and it's been shunting away from the vein. So we use a series of different technologies for thrombectomy, thrombosuctions, and thrombolysis to macerate the clot, and also to suck out the clot, and also to infuse lysis by catheter-directed thrombolysis. So after we did that, there has been some improvement. I think you will agree. Nevertheless, it's still quite narrow, the SMV here. Yeah, and we left this ECOS catheter here for infusion, catheter-directed infusions or thrombolysis overnight or for a few days. And this is the clot we aspirated on that case. You can imagine, this is quite substantial. And this patient will form clot as he was doing the procedure. They are pretty much procoagulant, procoagulopathy. So the more clot you suck out, the more clot it forms, and it continues the vicious cycle. So you do need to have some degree of thrombolytic agent and anticoagulation to help with the procedure. 24 hours later, the infusion, it looks pretty much improved. I think, the SMV, the splenic vein is open up compared to before. I did further endovascular intervention, including balloon dilatation, etc. Some improvement. This was 2 years later. This was his initial presentation with complete occlusion. And you can see here the TIPS itself is patent 2 years later, and also the SMV is patent. He's doing remarkably well, this patient. And the follow-up ultrasound shows patent portal venous system. Another patient with complex transjugular approach.
Why did that 17-year-old get that condition?
So I think he has got what we call the myeloproliferative, the mutation, So the other one, which is also very young, 28 years old, with cystic fibrosis, and obviously with liver, fibrosis as well, and presented with acute on chronic PVT with extension into the SMV and intestinal angina or bowel ischemia. You can see clots all over the portal vein and SMV. Not an easy procedure. So we got into the portal vein. Here you can see multiple clots. There is no flow whatsoever when you inject the contrast into the SMV. You should see some flow. Again, we repeated much the same. And you see here, lysis 72 hours, slightly better, not completely. And he developed ascites on day 5. I told you earlier on, you might not remember, but development of ascites during treatment is a poor prognosis sign that patient, sometimes may deteriorate. And because of the small portal SMV branch, I extended the stent along the SMV and then leave left a lysis catheter to infuse for a few days. This is day 10. Some improvement, not great, but certainly much better compared to when he first presented. Another case, this is a case of 40-year-old with, again, very young patient, cirrhotic with factor V deficiency. So we've came in with massive variceal bleed. And you can see here portal vein thrombosis, SMV thrombosis, quite a challenging case because of the anatomy, cirrhotic liver, very fibrotic. You can see I deployed the tip stand here, but then the wire came around here, quite convoluted, not easy. This is a recanalized para-umbilical vein here on this picture. Some improvement in terms of flow and pressure. We didn't leave the lysis catheter because his patient presented with quite massive bleeding. And this is 48 hours later, not much better, but slight improvement. But at the same time, he did receive, anticoagulation. So I thought I was going to, because of the difficulty to go in from the tip side itself, because of the angulation. So I thought I needed to go in to repeat the thrombectomy. And this is direct puncture of the portal vein with the catheter in it. Remarkably, this showed that the vein is actually patent, and I didn't have to do much. So this is a comparison at presentation and 3 months post-tips. You can see full recanalization of the SMV and portal vein. Last on the transjugular approach here, this is fairly recent case, 46-year-old post-gastric sleeve surgery from Turkey. We see this complication at least 3 times now in the course of over 1 year. Post-abdominal surgery presented with acute portal vein thrombosis. And you can see here the CT scan also show mesenteric ischemia. So we did the tips here and clots here and SMV clotted and lysis, etc. So this is day 3, year 5. You can see progressive improvement of the portal vein and SMV. And here's day 6. You can see SMV is patent, portal vein and tips are patent. Unfortunately, the ischemia has not improved. In fact, it has got worse with mesenteric, inflammation and swelling, etc. Patient went to theater, and lo and behold, he infarcted the distal segment of his bowel. So this case, I think, highlighted the fact that probably the intervention for endovascular is a little bit late. We could have started early, but the reason for the delay, despite his CT appearances, patient was relatively stable and, not much pain, and hence the delay. I move on now to transhepatic assisted TIPS procedure. This is a young case, 35-year-old, again with previous acute pancreatitis. I told you about the non-malignant, non-cirrhotic cause. One of the causes is inflammation in the abdomen, including pancreatitis, and therefore patient have portal mesenteric spanning vein full-blown thrombosis. Presented with GI bleed. So CT show obviously obliterated SMV and portal vein, and you can see this collaterals here, carcinoma around the duodenum. He had previous coils here for elsewhere for GI bleed. So postulated that the duodenal varix here is the main cause of his bleeding on endoscopy. And because there is no way to do the transjugular approach, the vein is completely occluded. I came in the transhepatic approach. And you can see here, this is a wire going in, and it's leading nowhere because a lot of it has been occluded. The portal venous branches here, those are not normal anatomy. In fact, it's very disorganized. Ultimately, it's very, very tough, and we're going from the right portal vein branch here, and finally able to traverse here using very sharp recanalization technique. And then once we're in, we dilated the tract, and this will be the portal vein SMV, and using the balloon as a guide for us to come down from the jugular approach to puncture that area, and hopefully that will puncture the portal vein and being able to recanalize it. You can also use snare to snare where you puncture. So again, quite convoluted examination, but fast forward, TIPS was established, and we now have some channels across here and good flow across the portal vein and the SMV. However, despite that, he continued to have very severe bleeding or GI bleed. And then the CT scan, you will know this is Dave Bowden putting arrows, which is patent and not patent here. So here, portal vein here, TIPS is patent, some occlusive disease here. And because the inflow from the SMV is so poor, and I didn't think that there was much that we could offer, but you can see the substantial varix here around the paraduodenal area here. There's also endoscopies failed to address that, a quite difficult area to address. So we were asked to whether we can embolize that varix percutaneously. So patient came to a CT scan. So this is the varix here adjacent to the gallbladder, and this is the liver. And we did a transhepatic access to that particular varix. And I then moved him from the CT to angiography. It's only a few levels, but anything can move, yeah, the needle. So you will see here, he already got the tips, got already the coil from previous embolization. This is the Chiba needle, very thin. And then I tried to inject some glue, itself got occluded. So in the angio itself, I have to pass a second needle here using fluoroscopy guidance. And from there on, because of the, you can see faint contrast material here, this is all carcinoma, yeah, and draining into the liver. So you will see that if I inject anything liquid, it would definitely block off the entire liver. So with that in mind, I elected to embolize with some coils. And these are multiple coils that I injected, but still there is some flow across into the liver. But we want to retain the flow into the liver. Otherwise, you have no blood supply to the liver. What we want to do is to reduce the impact of paraduodenal variceal bleed for that particular patient. He did have some response for 24 hours, but then had massive ongoing bleed, which is very substantial overnight. And unfortunately culminating to us, having to embolize his SMA. And this is partially embolized, and remarkably at laparotomy, only a short segment of the bowel was ischemic, and the rest was actually patent, was actually viable, despite the partial embolization. So he had a protracted course during his admission, but managed to be discharged sometime after. So a very complicated case as well. Now, transplanting approach, I have not done that. I almost wanted to start on one case, which we decided not to proceed for various reasons, but essentially it's not dissimilar to the transhepatic approach. You puncture the spleen into the splenic vein and directly cross into the portal vein, use a balloon or a snare. You puncture from the transjugular approach, snare or connect the two and then balloon it, and you will see establishing the stent itself. This is another example where they actually put in two stents. So a few cases been reported in the literature. And I've seen a couple of cases here on the direct SMV and IMV puncture percutaneously using ultrasound. And this is again the work from Chicago. And so this is occluded portal SMV here that they managed to see percutaneously on ultrasound. I think they must have an excellent, very high resolution ultrasound. And I always think IMV is retroperitoneal, but somehow managed to get through percutaneously. So I'm not sure, I will ever try that. But there were a couple of cases being described. Really good result, apparently. And then we talk about collateral vein puncture, which is quite a high-risk intervention because, the collateral, the carcinoma, once you puncture, if you cannot connect it to anything and you leave a gap there, there is nothing to compress. There is no tamponade. It will just bleed with hemoperitoneum and patient may die as a result of that. In terms of selection, you need to select a vein which is parallel to the hepatic vein, and remarkable case that they did, a couple of cases described here, which established the flow here. And again, I think patient selection was very important here. And as I say, I've been asked to do this a couple of times, which I rejected. I think it's a very high risk intervention in terms of how beneficial it is for the patient. So all those complicated and complex intervention, what is the outcome? The reports in the literature are mildly heterogeneous, and not surprisingly, yeah, because there's no standardized description for all what we are doing here. And they will include cirrhotic and non-cirrhotic cohorts with varying degree of portal thrombosis. And not all papers were mentioned about whether patient has got carcinoma or not. The importance of that is that patient with carcinoma is extremely difficult to establish a TIPS shunt, very difficult to recanalize because they're very tough, yeah, and they are actually very high risk intervention. All in all, the technical success is about 75%. TIPS may be patent for about 70% for a couple of years. There usually will be multiple punches, and so far, those that we reported seems to be reasonably safe. And as I said, about 25% will be unsuccessful. About a third will require revision. This is a systematic review about 400 patients worldwide. Again, there is so much publication bias here. They see high, technical feasibility. I suspect purely because of varying degree of thrombosis, yeah, minor or moderate. Risk of encephalopathy is consistent with what we know, about 23%. Major complication, about 10%, including 7 deaths in the cohort. This is a paper from Chicago. Again, the center will do quite a lot of this aggressive intervention. And they have 39 patients, a combination of transhepatic, transplantic, and mesenteric approaches. And symptomatic improvement about 87%, but in 1/3 of them, the TIPS thrombosed, and quite a lot of them will require re-intervention. However, secondary re-intervention does improve the patency to 80%. And just bear in mind that these patients in the last 10 years, ago or 15 years ago, they would have been forgotten, yeah, because no one will actually go and do this kind of very complex intervention and very time consuming. Even then they describe about 4 to 8 hours of intervention. This is our work here in combination with the royal-free using a stepwise thrombolysis regimen. So basically, when a patient presented to us, they will have anticoagulation in low molecular weight heparin for at least 2 or 3 days. If that doesn't improve based on the CT scan and clinical status, they will have systemic altiplase infusion along with anticoagulation. And if that fails, then they will have local catheter-directed dissolution, for example, via TIPS. The indication are for acute PVT on patient with ongoing abdominal pain within the 30 days and features of intestinal ischemia or edema on CT. And of course, a lot of these patients, we do need to discuss it extensively. And TIPS in non-cirrhotics, because they don't have portal hypertension, we do not really need to decompress the pressure. However, it is a technique that will allow us to get into the portal vein for clot dissolution. So the result, and so about 90% of them has got extensive thrombosis involving SMV and splenic vein. And almost all have occlusion, and all patients with intestinal ischemia, and all will receive anticoagulation and systemic altiplase. About half of them receive TIPS. I think very good resolution of 90%, and any recanalization of 86%, including 50% of them with complete resolution. So we think that there was no death and 2 major complications relating to bleeding, which subsequently resolved. I think this stepwise technique is good in the sense that we receive referrals from a number of centers. It allows the local center to start the heparin infusion prior to the transfer here, because as you know, transferring a patient into hospital transfer could be very long, and we do receive patients from elsewhere, for example, North, Derby, etc. And we have a few from Scotland and also Northern Ireland. So in terms of transfer, it does take time, but it does give them opportunity to lyse the clot in the first instance. I'll show you two complications before I end my talk. So complications, one is encephalopathy. I say 23% of them in the cases. So this one is portal vein thrombosis, established tapes and a very nice flow, etc. Unfortunately, it came back with encephalopathy, with confusion, refractory to mannitol or other medication treatments. We do this procedure called tips reduction. Essentially, you insert this hourglass stent within the existing stent graft. This doesn't block the tips completely, but it alters the flow dynamic of the flow to reduce the flow and therefore reducing the risk of encephalopathy. The reason behind that is because encephalopathy, the cause of it is multifactorial, and one cause is the endotoxin, from the bowel, does not pass through the liver for filtration, and it goes straight to the systemic circulation into the brain, and therefore causing confusion and so forth. So that is the reason why to reduce the flow. But unfortunately for this lady, that doesn't work. She did not even improve, and therefore we had to in irony to what we've done for her, a difficult case, we had to block off the tips completely using this, what we call a plug here. This is when you deploy in the vessel to completely block it off to reverse or to improve the encephalopathy. This is a drastic complication that I encountered so far. So I have everything there, arterial, biliary, and so forth. So this is a patient 50 years old, presented acute and chronic portal vein thrombosis. You can see here, occluded vein here, and nothing in the SMV. I proceeded to do these tips, quite challenging, multiple punches, almost wanted to give up, including transhepatic and various approach to get in there. But finally, we got in there. I left two catheters via the sheath here. I deployed the stent, and one in the splenic vein, and then the other in the SMV. And then the next day, he became unstable. You can see the CT scan here, blush, arterial blush here, indicating hemorrhage in the liver. And Nick, you remember this case that you did an angiogram for me, and which shows extravasation here for multiple. It took you a little while, I think, because there are multiple sites of bleeding, and we try to preserve as much hepatic artery as possible, but it doesn't seem to be possible. So it has to be quite relatively, proximal embolization. You can see this is a hepatic artery here, and so ultimately we want to stop the bleeding, but unfortunately we have to devoid the arterial supply. And imagine this patient without portal vein supply, without the arterial supply, you know what is going to happen next. Despite that, the tips itself is relatively stable and patent, and you can see I deployed additional stent along the splenic vein and SMV, which looks pretty, really very good compared to his first presentation. So this is the CT scan brought forward now. He had obviously infarcted his right liver. And these pearly tips, edema here may indicate tipsitis. And as a result of the infarction, he also has some bowel leak, laparotomy, washout, etc. A very protracted 3-month stay in the hospital before he was discharged. Despite all that, his tips and SMV was still patent until I think 3 weeks ago. I was told he presented to his local hospital with GI bleed. They stopped the anticoagulation completely. And of course, the vein is now re-occluded. So it's a very sad case. So, but he's still alive and he's still dealing with it, but it's quite difficult. The last slide here, I talk about, the quite a complex condition, and the patient, tend to be quite isolated, and there is the psychology impact of portal vein thrombosis onto patients. So this paper highlighted the discrepancy between patient with or without portal vein thrombosis in terms of diagnosis of anxiety and also depression. Nevertheless, it is a condition which is, we can be life-threatening, debilitating, and very difficult to deal with. And certainly, I know of one of my patients, despite the recolonization, good flow, etc., did actually commit suicide not long ago. So we should not underestimate the enormity of this condition on the psychology aspect of for the patient. So in conclusion, to date, the literature that's available in terms of evidence-based management of pulmonary thrombosis is quite limited. We base on cohort of case, selection. We certainly need more structural classification in terms of the diagnosis itself, and also perhaps some other biomarkers to identify those patients who are at risk. And almost all of them will need individual treatment, because not one is the same for other. And I think majority will require some degree of anticoagulation, low molecular weight heparin. I think that there is a wide scope to further innovate the endovascular approach, being from whatever transhepatic, transplanic, to make it more durable and also safer and more effective for the patient. Thank you.